All right. Hello, everyone. Again, thank you for joining us. Welcome to NDD's webinar titled Advantages of Point of Care Lung Testing in Interstitial Lung Disease, or ILD. My name is Jamie Burgess, and I'm an RT with NDD.
And I'm Darren Fitzpatrick, and I'm also an RT with NDD. Joining us today for our discussion is Dr. Anoop Nambiar. Dr. Nambiar is the founding director of the Interstitial Lung Disease Program at UT Health Science San Antonio. Thank you for joining us today, Dr. Nambiar.
Thank you so much for having me. Really appreciate the invitation.
Yeah, absolutely. A few quick housekeeping points. Make sure, as always, we're going to have that question and answer bar open on the right-hand side of your screen. Feel free to type questions in there at any point. Just know that we'll probably wait till the end of the webinar to address those, but we will get to them. So when they come up, put them in that chat bar. There will also be a post-webinar email sent out that will have Darren and I's contact information for those questions that may come up later. And then also it will have a recording of this presentation too, so that you can reference back.
Perfect. Thanks, Jamie.
All right, webinar objectives. So we're going to start out with our Q&A with Dr. Anoop Nambiar on DLCO testing in his patients with ILD. We're then going to learn about the significance of DLCO testing in diagnosing and managing ILD. We're going to understand the importance and important benefits of portable point-of-care PFT devices. We're going to learn about NDD's patented TrueFlow technology. Review the possible effects of COVID-19 on lung function. And then last, we're going to see a live demonstration of a DLCO test on the EasyOne Pro device.
So without further ado, we'll go ahead and get started with our Q&A section with Dr. Nambiar. And Dr. Nambiar, again, thank you for joining us. We appreciate it, especially I know it's probably busy for you right now. But we wanted to go through a few questions because we really feel that the presence of DLCO right now being available at point of care for patients with ILD or interstitial lung patients has really become more of a thing. We see more and more physicians purchasing DLCO devices for their offices. So Dr. Nambiar has been a friend of NDD for 5 or more years, and we really appreciate you again jumping on. So our first question is, could you give us a brief overview of what interstitial lung disease is?
Sure, of course. I think this is extremely important to talk about, to make sure that everybody on the webinar and anyone who watches this later on or that is on the same page. So interstitial lung disease, or ILD, it basically is a large family of different lung diseases that really cause interstitial inflammation and or fibrosis. And that's important to remember because it can oftentimes be mixed, and it is actually oftentimes mixed. Sometimes they're more fibrotic and sometimes more inflammatory. But ultimately, the sequelae is reduced gas exchange, and ultimately the lungs start to become stiffer and smaller in size. And what the patient experiences, which is obviously one of the most important things, is shortness of breath and cough. Also, you can also say shortness of breath more so with activity and reduced exercise tolerance. And a big problem with ILDs, as opposed to maybe some other diseases, is that ILDs oftentimes are progressive, which means that they inevitably get worse in many cases. And then that leads to respiratory failure and, unfortunately, death for these patients.
Absolutely. Thank you. What are the I know you just briefly went over those, but what are some of the common symptoms associated with ILD when you have a patient come in that you feel that this might be a time to do some testing when it comes to ILD?
So I think most people would say that probably the most common symptoms would be shortness of breath, typically with exertion first, and as the disease progresses, then people usually get shortness of breath at rest too.
Okay.
Cough is a very common symptom. Exercise capacity reduction. So in terms of, I still remember a 90-year-old patient of mine with IPF who said that he was walking or walking up to 2 miles 6 months ago, and now he's only walking a mile. And to me, I'm thinking that that's still a mile more than I do, but for him, that's a major change. And those are really important things to recognize, is for that individual person, what's their baseline and what kind of change has there been to make you suggest and think about the possibility of interstitial lung disease.
Okay, absolutely. I know some patients sometimes, like your 90-year-old, just feel like it might be with age, and disregard those symptoms as just getting older. So definitely ones to keep in mind. Our next question is, why would you use DLCO in diagnosing or managing ILD? What have you found to be, why has DLCO become important in your practice, in your point of care?
No, absolutely. I think this is really important. DLCO is, and I'm maybe a little bit biased here, but it's one of my favorite physiological tests what we do in the pulmonary function lab. Of course, we know about spirometry, and I'm not discounting spirometry because I'm a lung doctor. So spirometry is essential. It's key, especially though to identify those patients with airflow obstruction. But I think DLCO, even though it's very important, I think a lot of people know it. I think it's under-recognized, and I think it's underutilized. Absolutely. So having this discussion is extremely important. And so one of the key things to remember is that in patients who have a restrictive physiology on spirometry, in the presence of a reduced DLCO, it must trigger the thought that this could be interstitial lung disease. And so on this slide, you can see on the left, this is taken from a very good review article on idiopathic pulmonary fibrosis in the New England Journal of Medicine 2018. And as you can see on this list of symptoms based on history and signs and examination findings, you can see the low DLCO is one of the key physiological findings to make you suspect and also consider the possibility of an interstitial lung disease. And so it's nearly universal in IPF when other findings are absent in early stages of disease. This is something that I think needs to be a tip-off. When you see normal spirometry with a reduced DLCO, there could be something going on, such as ILD and IPF. It should be performed in any patient suspected of having ILD and or IPF. And if it's reduced, in my opinion, that should trigger a high-resolution CT scan to, number one, confirm the presence of ILD, number two, determine the severity of the ILD, and number three, maybe more important, try to identify any clues, signatures that suggest an alternative diagnosis, perhaps to something like IPF, such as chronic HP, if there's air trapping, or certain changes like that could help you really to make sure the diagnosis is right for that patient.
Absolutely, and I think I read a statistic, if I'm remembering right, that is it 500,000 patients are diagnosed annually with an ILD?
So we think, and this is something that nobody, I don't think, has ever really been able to nail down for sure, but in general, about 150 to 200,000 patients have IPF in the United States, and typically about 50 to 60,000 are diagnosed annually. That number most likely is much higher because IPF would comprise about 60% of ILD patients. So that number is going to be much higher for ILDs. And so we're now in this world where we used to only be thinking about IPF because it is the most common and the most deadly of different ILDs. But now I think there's more recognition, and there's actually now more clinical trials with treatments that actually can help patients with other types of ILDs that can be as progressive as IPF. And those folks, unfortunately, before did not really have much in the way of options for treatment. So
absolutely.
I think this is a great point you made about IPF, but also the world of ILDs is now something we all need to be more aware of.
And like you said, with the symptom is something as shortness of breath, or someone who just might think it might be with aging, and a physician does a spirometry test and sees normal. It's so important to do that next step. Especially if the patient is complaining that there has been a change in their shortness of breath level, especially with exertion, like you said, that adding that 10-second DLCO can make a life-changing diagnosis.
Absolutely. And probably another example, I think, which is really important to think about is a patient who's got both interstitial lung disease or fibrosis in the lungs in the lower part, and let's say emphysema in the upper part of the lungs. And so, as you know, and I know a lot of folks out there know, these folks will have normal spirometry, normal lung volumes, but have a severe reduction in DLCO. Absolutely. And if the DLCO is not done, you might think that this is something else other than their lungs. it might be their heart, et cetera, and go down a wrong diagnostic pathway, the DLCO really would be the tip off that there's something very, very bad going on in someone's lungs. And those patients combined pulmonary fibrosis and emphysema also at increased risk for pulmonary hypertension and other issues, which also can compound the reduced DLCO. So that DLCO test is, again, not, I don't want to say I'm too biased, I'm a little biased, but it is the most important, one of the most important tests that we do in ILD patients.
Absolutely. And like you said, like we took out of that study that you proposed on your slide, was DLCO is nearly universal in IPF when it comes to the findings. And, you know, we're a big proponent for patients also knowing their DLCO value, especially patients with ILD diseases, that they know that. So when those DLCO start to fall, that they recognize that there's a change going on. So we'll go on to the next question. Could you tell us how DLCO is associated with increased risk and mortality in IPF?
Sure. So we've already talked about the importance of using DLCO in the diagnostic approach to patients suspected of having ILD and IPF. And let's just now fast forward and say that we have a confirmed diagnosis, ILD, IPF, and that baseline DLCO has been shown to be predictive of increased mortality in the short term, especially when it's less than 40%. That's a number that I have, you know, I learned when I was doing my fellowship training at Michigan, and I've kept with me as a number that also reflects oftentimes when patients have significant exertional desaturation. And so we also know that's associated with worsening mortality too, when you have reduction in your oxygen saturation, as you can see on the slide here in the baseline factors. It also has been shown, I think we have a next slide where that correlates with the extent of fibrosis. So it does give you that kind of physiologic look almost into the morphologic aspects of the lung, what's going on in the entire lung, and especially with scarring in the lung. But we also have to appreciate the fact that longitudinally, as you go back to that previous slide, the reduction in DLCO over time is extremely important. And so a reduction in DLCO by 15% or more absolute value over a 6 to 12 month period has also been associated with increased risk of death. So having that baseline DLCO, we talk about important for diagnosis, also important for disease severity, and trying to predict at that time what's the future going to hold for that patient, which could be extremely important in the sense of, should I refer this patient on for lung transplant? Of course, if the diagnosis is IPF, as soon as that's made, somebody should be referred on for evaluation for lung transplant if there's no obvious reasons that they're not a candidate. But also having that low DLCO in a non-IPF ILD would also make you think that this person has a higher risk of having a big problem short term. And then following them will also tell you that if their DLCO is dropping, that's a sign that either their pulmonary fibrosis, their ILD is getting worse, maybe they're also developing pulmonary hypertension. That is also something associated with increased mortality.
Absolutely. And again, this is just to reiterate the importance of DLCO in, you know, patients with ILD, like you said, to diagnose, but also to manage. So this, you can go ahead. What are your recommendations on monitoring patients with ILD using DLCO? I know you kind of just touched base on that, but stressing the importance again of, you know, how do you use it to monitor your patients? How often do you have them come in? And
no, I think it's a fantastic question. So now we're kind of moving forward in that patient's journey with ILD and IPF. And so we've made the diagnosis, we've made a determination as far as their severity and implementation of treatment strategies, let's say. How do we monitor? How do we monitor them in terms of how they're doing? Are they, you know, we're not at the point where we have treatments that reverse fibrosis. If we get to that point, then we may actually see not only stabilization of DLCO, but perhaps even improvement. And to me, that's the ultimate, where we actually can make people feel better and we can see that physiologically. We're not there yet, where the best that we can do right now is slow down disease progression IPF, maybe in some cases stabilize other types of ILDs with the right treatment. But the DLCO needs to be monitored. And I typically follow the 2018 IPF diagnostic guidelines and the previous iterations, which have recommended follow-ups every 3 to 6 months for symptom check, but also for PFT checks, which included FTC and a DLCO. And the reason being that to get that sense of, is their disease staying stable? Do they seem to be responding to treatments in the sense of they're not progressing significantly? Because if the DLCO is dropping, FTC is dropping, then typically that's a bad prognostic sign. So we need to be monitoring those patients, which then would help us to make adjustments in terms of treatment. So even though I'm a big proponent of earlier treatment for IPF with the available therapies, I would also say, these are therapies that sometimes patients who might have mild disease may not be convinced that it's worth the risk for the potential benefit. So follow those patients, and if those patients start to progress, they will, and they start, especially if they start feeling things that are different or changing. You correlate that with the DLCO showing also that it's dropping. To me, oftentimes patients need that biofeedback that there is a change in their lung function, their diffusion, correlating with their symptoms, and then institute the right treatments at that point too. So, or refer on for lung transplant. So these are things that, in order to really make sure that we're taking the best care possible of our patients, we have to not only get the right diagnosis up front for ILD, the type of ILD they have, we have to monitor them appropriately and make sure that we are able to change this management strategies as things dictate.
Absolutely. And again, at NDD, I just touched on before, we really do believe that patients should understand their DLCO. And like you just said, it might be that them watching that physiological change that gets them to understand the severity of their disease.
Absolutely.
So thank you. And what we'll do is we're going to keep you on, so don't go anywhere. And we're going to switch a little bit over to, I know there's obviously the big question right now is COVID, and we have a slide that Jamie's going to go ahead and review, and then we're going to come back to you and talk about how you're instructing your ILD patients to be vigilant and careful during this time, especially with COVID. So I'll switch it to Jamie real quick, and we'll come back to you.
Yeah, absolutely. Thank you again. So we just wanted to go through briefly what we know right now about COVID-19 and lung function. COVID-19 is affecting the respiratory function of the people that are catching it. Permanent lung scarring and reduced lung capacity are real outcomes that we are seeing from COVID-19. Some COVID-19 patients are developing ARDS, or acute respiratory distress syndrome, which is a life-threatening lung injury due to infection. This causes people to be hospitalized. These are the patients that you see on ventilators. This is kind of the worst case scenario of the virus. Some experts are saying that it can take 3 months to a year or even more for a person's lung function to return to their pre-COVID-19 levels.
So definitely we know that it's affecting it, and we are getting, that we are a PFT company, obviously we're getting a lot of emails and calls in regard to starting to test again. But Dr. Nambiar, maybe you can shed a little light what you are instructing your patients, or what you've seen with COVID, especially with your patients with ILD, or if you've had any patients with both going on right now.
No, I think this is obviously a really important topic right now. We're dealing with this global pandemic, and it's affecting a lot of people, and it's also unfortunately taking a lot of people's lives. And I think nobody knows really what's going to be happening moving forward. But I think this is really important to talk about, that if we extrapolate from previous kind of situations, things like ARDS, which is brought up here, we know that ARDS patients are at a higher risk for developing, especially when they have severe disease, developing post-ARDS pulmonary fibrosis and scar tissue that is irreversible in many cases moving forward. And these patients have not only significant physiologic impairment, but it translates into a very significant quality of life impairment, and survival potentially could be adversely affected too. The problem is right now we don't know enough about COVID-19, because it's really only been since December that we've even heard about this, hence the 19 and COVID-19. Only time is going to tell But extrapolating from our past, these are folks that need to be monitored right after they are discharged from the hospital. So I'm actually part of our local VA post-COVID convalescent team, and I'm in charge of the pulmonary program. And so that involves really monitoring these folks closely for their symptoms, their quality of life, using questionnaires, PFTs, 6-minute walk tests, CT scans at regular intervals post-hospital discharge, post-diagnosis and management. I think DLCO here is going to play an integral part because of how important it is to consider and diagnose patients with interstitial lung disease, and to monitor these folks who may have residual pulmonary dysfunction as a result of their severe, COVID-19 infection and pneumonia. We need to monitor these people. These folks have to be watched. Whether we can do anything about it, that's to be determined. Right. We're still trying to figure out how to treat acute infection, let alone think about post-acute infection. But I think these people, we definitely need to keep an eye on them. We need to monitor them in the clinic. We need to watch their lung function, and we need to gather data because as we're gathering data for what's going on right now with patients, we also need to gather data about what happens after, because it's really only the beginning if you have the infection. If it affects your lungs and then you have hospitalization for pneumonia, it's likely it will lead to long-term sequelae, unfortunately.
Absolutely. Yeah, thank you for sharing that. And it's definitely, like you said, it's something that's so new. I mean, we're all figuring this out together right now. Obviously, we understand that those pulmonary function tests may not look the same in the beginning, but hopefully as time goes on and their lungs heal, hopefully those numbers will get better. So Dr. Nambiar, if you don't mind hanging on, and I know there'll probably be a lot of questions, and those of you who have questions for Dr. Nambiar, you can see the question box that Jamie spoke about earlier. Go ahead and start typing those in. Jamie and I will go through a couple more slides, show you a quick DLCO test, the simplicity and the ease of it, and our technology that's a part of this. So Jamie, we'll go ahead, and Dr. Nambiar, are you good hanging on for a little bit?
Absolutely, as long as you need me.
Thank you.
Sounds good. Guys, we're hearing more now than ever that health systems are looking to decentralize PFT testings in the wake of COVID-19. The need for post-infection surveillance using PFT testing is quickly becoming the norm. We are hearing about it every single day. PFT labs are often located in the hospital setting, which is making them inaccessible at this time for many patients. Even in the best of circumstances, wait times are often long, and a patient's compliance to actually return to the lab for testing can be a factor. The ability for a provider to perform both spirometry and full function PFTs, including DLCO, in their office, we think is going to be crucial to treating and watching these patients.
So advantages to point of care PFT testing with the EasyOne Pro right here sitting next to me. There's no need to send to a PFT lab. Again, we're not trying to take away from a PFT lab,
right?
But this also gives the opportunity, like Dr. Nambiar, that if you need to watch that patient every few months and really watch what's going on with their DLCOs, you can easily be done right here in your office. It's compact, portable device, making testing more convenient without compromising quality results. No issue with cross-contamination, spread of germs, testing right at the bedside, brings the diagnosis right to the patient, takes up little space, and instant results.
Right. I know that we have lots of friends of NDD on the call, but we wanted to do a brief overview about what makes our technology just so different from other devices on the market. And the first one of those is the advantages of our TrueFlow technology. Ultrasonic flow measurements are highly accurate in all flow ranges. TrueFlow technology has been proven accurate, independent of gas composition, pressure, temperature, humidity. It's resistance-free. It has open flow mouthpieces. It is the only technology that has been proven to require no calibration over its lifetime.
One of our other technologies, patented technologies, NDD's TrueCheck technology. This ensures that each DLCO trial is accurately validated without calibration warm-up time. Eliminates the need for gas calibration as well as the need for external DLCO stimulator, checks gas sensors, linearity and delay, checks for leaks in gas concentrations, and patented technology. It's something that's done before every single DLCO test and every single washout test. The device will do a TrueCheck.
Yep. All right, I'm going to switch my screen over. We're going to do a live demonstration. I'm going to have Darren be our patient today, and we're just going to show you how quick and easy this DLCO test can be done in your office. We're going to start with just some tidal breathing. The device is going to take that measurement when the patient takes a big deep breath in, and it really is just a 10-second breath hold. DLCO kind of has a reputation of being a complicated test, but it really is not. And from everything we've heard today, the value that can be obtained from DLCO is so worth a 10-second breath hold. So let me, excuse me while I kind of get my screen switched around here so that you can see what we see during this DLCO test. All right, there it is. All right, so Darren, go ahead and make your good tight seal. We're going to start with some tidal breathing, just normal breaths in and out. Very good. The patient's just setting that baseline. After this next breath, I'm going to have Darren empty her lungs all the way out. The device is looking for that plateau. When she reaches that plateau, it'll inject the gas mixture, and Darren will take a big deep breath in. There it is, big, big, big. She's going to hold her breath, count down 7, 6, 5, 4, 3, 2, 1, and she's going to relax and let out all that air. Go ahead and take that mouthpiece out of your mouth there, Darren.
Thank you.
Okay. It'll analyze the data quickly, and as you can see on my screen here, you do get those instant results. We do 2 trials 4 minutes apart, just to give the body a chance to flush out the CO from the mixture. And as you can see, we have all of those results in real time. You could see there, we kind of bypassed, I already had it set up to bypass our TrueCheck there so that we could just get straight to the test. But as Darren said, it does that TrueCheck calibration before every single test so that you know that your results are accurate. You get them instantly, and it really just is as easy as Darren just demonstrated, for sure.
Absolutely.
Okay, I'm gonna go ahead
easy
and
on the patient too. So
yeah, switch back over to the presentation here. All right.
Just a few bullet points on the EasyOne Pro. Again, the portability and compact for bedside or office testing. It's only 1 square foot, 17 pounds. Simple and easy to use with intuitive user interface. It really does walk you through and the patient through every step of the way. Easy and accurate diagnosis using ATS-ERS interpretation tree, as you can see in the bottom left corner. Something that Dr. Nambiar touched on is, again, when you're on the left side of that tree and you're highlighted down to normal, but all of a sudden you have a low DLCO, that's what you're looking for. And no warm-up time and automatic calibration. So that interpretation tree is on every printout if needed as well.
Absolutely. So as we start to kind of wind down here, I just wanted to go back through some of the key takeaways from our presentation today. We hope that everyone understands the importance of DLCO in ILD, understands a little bit better the advantages of point of care lung testing, and understand the benefits of NDD's technology.
Absolutely. So what we'll do is we'll open up for some questions because I'm sure we have some on here. So I'll go ahead and have Jamie open up her computer. So if you guys have questions for us or for Dr. Nambiar, we're gonna go ahead and get those going. We'll try to, sometimes ours are hard to see.
Yeah,
so.
Bianca, you might have a better visual because mine always show up so tiny on my screen.
Yeah, perfect. I'm just going to unmute myself here. And I do see a couple questions coming through. So I'll go right ahead here.
Yep.
One of the first questions here from Graham is, in a managed care office setting, if you bring DLCO into the office, does this help reduce referrals to pulmonary?
Dr. Nambiar, do you want us to start on that, or do you want to answer that first? Or
No, feel free.
Okay. We actually, the feedback that we've gotten over the past 10 years that the device has been out, I think we actually help refer those to pulmonary. When it does, if it is a internal medicine office that does see something like what Dr. Nambiar spoke about, a normal spirometry, but all of a sudden this low DLCO, that's when they're referring out, which that patient could have been missed at that point because they would have stopped his spirometry normal and sent the patient home. That next step was done, then they are understanding that there's more in-depth, diagnostic needed, and usually that's when we send out to pulmonology.
Right, it really just gets patients into the hands of pulmonary faster.
Anything you want to add to that, Dr. Nambiar?
No, I agree with everything that's been said. Also add that, like we talked about before, someone's spirometry could be normal and even lung volume is normal, but the DLCO being reduced, if it's not in the presence of somebody actively smoking or having anemia, a known or presence of anemia, which can also reduce the DLCO, that would be something that's abnormal and needs to be worked up further by a pulmonologist.
Yeah, absolutely. Thanks for asking, Graham.
All right, wonderful. Thank you. Another question here from Sharon. What measures do you recommend to avoid contamination while testing COVID-19 positive patients?
I mean, and Dr. Nambiar, feel free to jump in. Usually, most PFT testing isn't done on an actively sick patient. It's just that's something that we don't recommend and ATS doesn't recommend, but Dr. Nambiar, would probably have a better response.
No, I agree. The thing is that what we talked about before, we're learning about this virus. What we've known, what we found out so far is that it can persist on different surfaces, and including plastics and metals and things. So we basically, as of mid-March, stopped doing any PFTs on anybody, in our lab is still closed to all non-urgent cases. So things like, obviously, patients who have lung cancer, who need an urgent surgery for curative intent. Those are folks that we might make an exception, but get tested beforehand to make sure they're negative if we do that test. And as far as specific, cleaning and things, I mean, that I probably have to defer to my infection control people and you all about anything to do that if we were to do a procedure on it. I just would not recommend it right now on anybody who has a suspicion or have confirmed case of COVID-19. What we're doing in our convalescent program is waiting at least a month, which we think should be sufficient after they've been diagnosed, treated, and after discharge before we bring them back in the PFT lab. But you'd want to get your infection control folks to make sure that if you do bring them into your clinic and your hospital or to do PFTs, that they are cleared and not potentially having a virus, active viral infection that could transmit.
Absolutely.
Right. And we've seen this, we've had this question coming in a lot, and, just like Dr. Nambiar spoke, we really have to refer to your facility, your hospital, your doctor's office, to what your policy and procedures are at this point. Obviously not testing someone who is ill, who is actively ill, people that have been traveling recently, people who are running a fever. If you do test, making sure that your staff is in the proper PPE. Taking those general precautions, I mean, I think that applies to the pulmonary function test lab as well.
Absolutely. Thank you.
And as you both know, you mentioned it just now, that typically doing PFTs on folks with an active process is not going to be all that useful or helpful. In fact, it's usually be poor quality, and poor quality, as the saying, I guess the old saying is, garbage in, garbage out. It's not going to be that useful to diagnose or treat somebody.
Absolutely.
I think a month, sometimes even I would say 6 weeks, probably you'd want to wait till to allow full recovery of their active illness before you then look for what's the status of their chronic problem. We're doing a month out because we want to identify, since these post-COVID patients have not had any physiologic measurement up to that point. That's why I would say a month is probably the earliest that you'd want to do it, to at least see where they're at, and then that way you can have now a baseline post-hospitalization where they're at. Then you can follow that. But I would say, to me, 4 weeks after an acute process is the minimum amount of time.
Okay. Yeah. Thank you. Good advice.
Perfect. Thank you. We have another question here coming from Michael. Could you make a comment about DLCO correction and interpretation?
Sure. So bottom line is I don't do it, especially not for ILD. There may be other circumstances and patients with pneumonectomies and maybe significant bolus disease from emphysema. But in general, it's really a misinterpretation. It's a misnomer Maybe Darren, you guys can also comment on it, but it's really, it's not truly the corrected diffusion capacity for alveolar volume. It's really, that's inaccurate. And so what you will, if you do use it, and I see this on reports still to this day, when you look at the DLVA in patients with ILD, oftentimes it may be normal or high. And that's only going to give you a false sense of security when the DLCO, the actual, their true DLCO is actually low. Then you can actually miss a lot of patients, and also it's not going to be helpful in monitoring and following patients. So it's something that I just would not recommend. And you guys can maybe comment a little bit more on DLVA, but it's
no,
really
we agree. I mean, we rarely see it anymore. No one too much is, you know, especially over here in the States, we don't see it as much as that KCO measurement. So.
Yep.
Perfect.
All right,
Thanks,
guys. I think that's all we have for questions today. Thank you.
Okay.
Thank you guys so much.
Awesome. Well, thank you guys so much. Again, keep an eye out for that follow-up, the post-webinar email. It'll go out. It'll have, you can see it here in the presentation as well if you want to jot it down, but both Darren and I's contact information, the website, nddmed.com, it just has a wealth of information if you want to dive into some studies we've been a part of, other information, more information about our products, and then in that email there will be a recording of this, and then eventually it'll go up on the website as well. So Dr. Nambiar, again, thank you so much for joining us, and we look forward to seeing everybody again at the end of this month.